Hello everyone. Today we are going to talk about and discuss the question paper of DrNB Cardiology, October 2023, paper 3. We'll be discussing each question in brief as to just to guide you and make it easier for you to revise during your exams. So the first question which came in exam was heart failure with preserved ejection fraction, the current management for it. So heart failure as per the ESC guidelines 2023 update is defined is of three types. First is the heart failure with reduced ejection fraction, which means that ejection fraction is less than 40%. That is less than 40% is called as reduced ejection fraction. Mildly reduced ejection fraction is nothing but 41 to 49%, and more than 50% is called as heart failure with preserved ejection fraction. There is one more entity which is called as heart failure with improved ejection fraction, which means that where patient has initially had EF of less than 40%. Now, after the therapy or treatment or intervention, EF has improved to more than 40%, is called as heart failure with improved ejection fraction. So, current treatment guidelines for heart failure with preserved ejection fraction. Previously, they used to say the only way of treatment is to treat the risk factors. Treatment of risk factor is the most important one. That means the most common cause for heart failure with ejection fraction was hypertension. So treat hypertension well, maintain control diabetes. So all this, so treating of the risk factors was the only treatment available for that. Now, suppose the patient have congestive symptoms, then only have to use diuretics for them. So the current guidelines after the lot of evolution, two more drugs which has been added is one is SGLT2 inhibitor, that is sodium glucose transporter 2 inhibitor, and especially on which is dapagliflozin and empagliflozin. So this has received a lot of interest in research as well, and based on the trial of preserved trial, there is EMPA preserved trial. The recommendation has given that SGLT2 inhibitors can also be used in patients with heart failure with preserved ejection fraction, and it has got a class 2A recommendation. That means the benefits are much better, more than that of the risk associated with it. And another drug which can be used is the mineralocorticoid antagonist, that is MRA, mineralocorticoid antagonist, that can also be used. So SGLT2 inhibitors, which was discussed based on Emperor Preserved trial, which was done in a population with EF of more than 40, but majority of patients had more than 50%. They tried to see the following outcomes, that is the composite of cardiovascular death or heart failure hospitalization. So both death and hospitalization they tried to measure. However, the outcomes was much better in reduction of heart failure hospitalization. So there was significant reduction was seen, and it was mainly driven by the heart failure hospitalization. However, the mortality benefits was not much. It was slightly better than that, but was not statistically significant. So basically, it has reduced the heart failure hospitalization. That itself is very important in any patients of heart failure. So currently, it is class 2A recommendations. Similar study was done, which is also known as Deliver trial, which also showed EF taken patients of more than 40%, and they also observed similar findings when compared to Emperor preserved findings. It's coming to mineralocorticoid receptor antagonist. The trial is called as the TopCat trial. TopCat trial, which was done in patients of EF of more than 45% with symptomatic heart failure. Primary outcome was cardiovascular death, aborted cardiac arrest, or heart failure hospitalization. So there was no difference which was found in primary composite outcomes. But when we saw about only heart failure hospitalization, so there was significant reduction in heart failure hospitalization in patients with EF of more than 45% as well when this was used. So it is currently class 2B recommendations for mineralocorticoid receptor antagonist in heart failure with preserved ejection fraction. So based on the guidelines coming to, so patients with heart failure with preserved ejection fraction and hypertension should have medication titrated to control the blood pressure. SGLT2 inhibitors can be beneficial, which is class 2A recommendations. MRS can also be used, which is class 2B. In selected patients, there have been also studies which are being done on ARNI, and which may also be said that they can also be used, but it is still a class 2B recommendations for them. So ARNIs and ARBs. However, there is no benefit of routine use of nitrates or phosphodiesterase 5 inhibitors to increase the activity or quality of life. So that finishes our first one A question of heart failure with preserved ejection fraction. Second question was given as Victoria trial. Victoria trial was nothing but is based on vericiguat in heart failure. So vericiguat is a soluble guanyl cyclase stimulator. So what does it does is it stimulates and lead to conversion of GTP into GMP, which has a various roles. So this Victoria's trial was basically done in patients of less than heart failure with reduced ejection fraction or EF of less than 45%. And this was compared with when guideline directed medical therapy was given. Along with that, on half of the patient vericiguat was added and remaining half of patient we took as placebo. So they took any patients of heart failure with reduced ejection fraction. That means a high risk patient was taken. That means patient who had a recent hospitalization or a need of IV diuretic injection. So any patient who required recent IV diuretic use or recent hospitalization and also having elevated NT-proBNP, those patients were taken, and that was around 5,050 patients were included in this study. So half patients received vericiguat. Initially, the dose was started based on 2.5 milligrams once a day. It was slowly escalated every 2 weekly by 2.5 to maximum dose of 2.5 milligrams. So it was compared with placebo similarly. So what are the outcomes they saw was that vericiguat primary outcome was cardiovascular death or first heart failure hospitalization. The primary outcomes was almost similar with no statistical significance. As you can see, p-value is here 0.02 and it is not less than 0.05. Sorry. So the primary outcome was significant, but this majorly significant was seen only on the basis of heart failure hospitalization, but not based on the cardiovascular death. So basically, by using vericiguat, the increasing heart failure hospitalization was very much reduced, but there was no overall mortality benefit which was seen in these patients. So that from any other cause also was no significant difference was noted. So when coming to safety wise, it has shown to have a symptomatic hypotension, which is the most common side effect because vericiguat leads to increased GMP, which causes the vasodilation. So that is the major concern which stays always. So symptomatic hypertension was developed in 9.1% of patients versus 7.9 in placebo. Syncope was and anemia was almost similar, and anemia was more common with vericiguat. So in this study, the final conclusion was that vericiguat modestly reduced the risk of CV death or heart failure hospitalization in high-risk heart failure with reduced ejection fraction, which was already on standard therapy. That means the patient who are already on standard therapy, they had a very good effect here. So coming to some points about vericiguat, it is a soluble guanyl cyclase stimulator. It converts GTP to cyclic GMP. So this GMP has a various role. First, in the heart, it helps in preventing the cardiac remodeling, that is increases the ventricular relaxation, decreases ventricular filling pressures, decreases the hypertrophy, decreases fibrosis, increases the coronary blood flow. In the blood vessel, it causes vasodilation, decreased fibrosis, increased vascular distensibility. In kidneys, it has a renal protection role by it decreases the fibrosis and increases the blood flow. So dosing, when coming to the dosing, the usual dose is 2.5 milligrams once a day. You have to give with food. You double the dose every 2 weeks to double the dose to reach the target dose of 10 mg once daily. And routine monitoring of renal function or electrolyte is not required. However, blood pressure should be monitored due to the risk of hypotension. So that finishes our first question. That is 1A and 1B. 1A was heart failure with preserved ejection fraction, and 1B was Victoria trial. Please watch our next video for questions 2A and 2B and so on. Thank you.